Everyone. So everyone, most of you, I think, on the line will probably be very familiar with what I'm going to talk about. So I don't have a whole lot to say. I just wasn't sure who would be registering today, and I wondered if we would have some newer sort of attendees who maybe didn't know anything about SPORE or patient engagement. This audience probably does. So forgive me for the next few minutes for those of you who already know it all. But if we have someone who joins in a little bit or listens later and maybe don't, that's kind of where I'm coming from before I hand it over to Shane so he can talk about some of these sort of principles in practice, right? And Shane is going to advance me on here because he's very technologically advanced compared to me. So whatever this platform is, I said, Shane, I don't understand. Please advance for me. So let's talk a little bit about SPORE. So when Shane was thinking about his PhD research, and we didn't have a whole lot of time, by the way, for a variety of reasons. So it's a relatively short project, but I said to him, you know, Shane, are you familiar with SPORE? This seems like a great project where we should engage with the community. And Shane was quite open to that. So I think most of you will know this is our sort of national strategy for patient-oriented research being administered by CIHR, of course, one of our major funders of health research in Canada, ultimately focused on improving outcomes, right? That's really what we all want to do, all researchers, I think, and patients and families and providers and all of us with a stake in the system. That's really what we want to do. But SPORE is aiming to do that by partnering with patients and families and trying to create a new research culture, really, that achieves these real world impacts. So things that matter to patients and families, ultimately by partnering with them. And that's really the little bit of a difference, I think, in SPORE compared to other sorts of research. All right, Shane, advance me on, please. So in Newfoundland Support, as again, most of you will know, that's one of the units. It's one of the ways that SPORE actually plays out across the country. Because when you think about it, we can't expect people, providers, patients, families, researchers, administrators, et cetera, to just know how to partner together to do this research. So CIHR or SPORE has these support units across the country. They are specific to each province, excepting the Maritimes. So there's one for the Maritimes, but otherwise the territories and other provinces have a support unit. And our goal, what we're supposed to be doing is, you know, building capacity in patient-oriented research, you know, creating all the resources, both human resources and other toolkits and otherwise, that will help each province or territory sort of grow and achieve this culture change, right, of patient engagement, patient-oriented research. One of the things that we try to do, all the units, is focus on the things that matter in that jurisdiction. So, for example, colleagues of mine in Quebec tell me that their key stakeholders are focused almost exclusively on primary care. That's very important there. Here in our province, you all will have seen in the last several months now, all of the health accord work, right? That's been a priority in our province, for example. But that's the great thing about the units, because they're local, right? In each province, in each jurisdiction, we have the ability to focus on those priorities that matter. Next slide, please, Shane. So I've been talking about patients, right? And there's quite a lot of discussion about that term. Around the National Patient Engagement Community of Practice, we talk a lot about this. And I remember way back when SPORE started, literally back in 2015, I remember having this, some of my colleagues from Alberta and Saskatchewan were saying, I hate this word. I hate this word patient, but we have to use something. But the point I want to make for those of you not familiar, it's really quite broad. So we don't just mean people who have lived experience of a particular health issue. So someone who has lived experience of cancer, of diabetes, of hearing problems, etc. But it might be their family or friends. So it might be caregivers, partners, spouses, who are also impacted by that condition, but may not themselves have it. It might be a group of people or a community, much like Shane is going to talk about today, a particular community. And why? Because they share experiences. They have lived experiences of this topic that matters. And it might be any single one of us. Think about the health accord. All of us as members of the general public, as users of a healthcare system, we have a stake, right, in what happens to our system, in what happens to our own health outcomes. So when students say to me, well, who do I choose? Who do I consult with? Who should my patient partners be? I always say, well, you have to think about what your question is, right? What perspective do you most need? So Shane today he really needed to hear from members of this particular community because his research question is all about that community. It matters. And so if you're not a member of that community, how will you know what the lived experience is, right, of these cardiovascular issues, for example, that Shane's going to talk about? So patient very broadly, very inclusive. Move me on, Shane. So patient-oriented research, what I've been talking about, this is just the formal definition. I know most of us have seen this many, many times, but if some have not, it really is marked by three things. It focuses on patient-identified priorities, hence the reason Shane went out into the community to say, hey, does this matter to you? Is this important to you? Engages patients as partners and improves patient outcomes. And I always gloss over the last one because I think, well, all health research ultimately wants to improve patient outcomes, right? I think all health research. So I think what really distinguishes patient-oriented research from any other kind is that number 2 point. It really does partner with patients. So now I very routinely have patient partners on my research team, just like I have an oncologist and a statistician and a nurse and whatever other expertise I need. Right, makes sense. So I love the line that comes from the UK, really, research conducted with rather than for patients, right? So we're really working with them and their expertise, whether that's a family member, a person with a condition, or a member of the general public, depending on what it is, they have lived experience of whatever it is we're studying. Perfect. Now, the last couple of slides I'm going to talk about really are, how can people be engaged, okay? And where in the research process or cycle. And really the answer to that is they can be engaged anywhere at any level. So there's no firm and set rule about this. When we talk about engagement, we generally talk about it as being on a continuum, ranging from sort of lower levels of involvement or ability to influence the decisions being made. And in research, I mean the research decisions being made. So what exactly is the research question? What are we studying? What method are we going to use? Is it going to be quantitative, qualitative, some mixed method? Actually analyzing the data. They have some or no influence on all of those different stages. So ranging from lower to higher levels of power. And this, the next slide here, well, Shane, you can flick me over. This is a schematic from the International Association of Public Participation. It's just one. There are dozens and dozens just like this, by the way. I just copied this years ago and I still use it because it still makes sense to me. If you look across that upper row, look at those words: inform, consult, involve, collaborate, and empower. So you can just look at the language. Think about the language: inform or consult versus collaborate and empower. You can see it even in the language, right? That the level of influence and partnership is going up as you move up that continuum. This little schematic is so useful for people who have never thought about this before, because in one little slide, one little page, which I do not have the ability to do, let me assure you, I go on and on, as you can tell already, it really sums up nicely what the goal is at any one of these levels, what your promise is as a researcher to members of the public or your patient partners, again, whatever your topic, whichever one is more relevant to you, and some methods you might use. So for example, let's just look at that level of inform real quick. What's the goal? Well, it's to provide the public. Now, by the way, the International Association of Public Participation uses the word public, but you could quite easily substitute the word patient in here. It's all the same. I'm going to provide you with information that will help you understand the problem, the alternative, and or the solution. My promise as a researcher is I'll keep you informed. How might I do that? Oh, I might have a website. I might have a town hall or an open house or a fact sheet. But come up at the level of, say, collaborate. Look at the difference in the goal there. I'm going to partner with you, the public or my patient partners, whoever, in each aspect of the decision. So the decision here means a research decision, right? All the decisions about a research project. I'm going to partner with you. And look at my promise. I'm going to look to you for direct advice and innovation in coming up with solutions. And I'm going to incorporate your advice to the maximum extent I can. in my research project. So I might use an advisory committee or some sort of consensus building methods. But the point all I want to make today is, do you see the difference in this continuum, right? Very low level of involvement up to higher levels. And people often say, well, which level do I choose? What do I do? What I say is, first of all, your patient partners will tell you how they would like to be involved, number one. So it's best practice to offer some sort of flexibility in that. Not everyone wants to be involved at really, really higher levels. Some will, some won't. Plus, part of it is going to be very practical. So in Shane's case, for example, I said earlier, this was a project that, for a variety of reasons, had to be done in a relatively short time frame. Doesn't really matter the reasons. Simple fact is, it has to be done in a relatively short time frame. So that does actually limit a little bit some of the levels that are available. All right, Shane, I think I'm almost done. I'm ready to hand over to you. I keep teasing about your research, so it's time. So again, you can engage patients at any different part of this research stage. And Shane, if you flick me on to the last slide, this just literally points out some of the different stages. So whether that's in the beginning when you're trying to come up with a study question or idea, so the preconception, figuring out what are the gaps in the literature. So for example, in Shane's work, we know actually that there's a real gap in this data that Shane's going to talk about today, for example, right? In designing the study, what methods are we going to use, actually carrying out the study, all the way to helping analyze data, and importantly, knowledge translation. How do we get the word out or share the findings from a study? I think researchers don't do that well sometimes, by the way, and I have found patient partners are super helpful in that regard. So that's it for me. I'm going to send it back to Shane. So Shane, you can get yourself sorted and get your slides open, but I'll just ask quickly before I sort of stop. As I said, I know most of us have been doing this work now for a while, but are there any questions for me while Shane is getting himself ready to go and tell us about his project? Anything about patient engagement or patient-oriented research? Does that make sense? I'm going to assume it all makes sense. But feel free, if you have a thought, put it in the, oh, thanks, Catherine. Catherine knows all about this stuff. Put it in the chat, guys, if something comes to you. And Shane, I have.
Thank you, Holly. I think you just cut off there. I think you said you're handing it to me.
Sorry, indeed I did. By the way,
okay.
Thank you for moving me along in my slides.
Thank you for allowing me to do a Prezi, because I just love how they just move around. So thank you very much. Alrighty, so like Dr. Etchegary said, I'm going to give a quick overview of my PhD thesis, and then I'm going to talk a little bit about not only community engagement, but also something that wasn't originally planned, but sort of fell into place through one of my PhD committee members, which I'll get to in a little bit. But I was able to speak with some experts in the field who had done research in this area back in the, I guess, protocol development stage. So I'll go into a little bit more detail on the expert engagement as well as community engagement after a quick overview of the actual project that I'm doing. So this is my PhD project for clinical epidemiology and the Faculty of Medicine at Memorial. There's three main, I guess, components. The first one, the more technical component, would be a regression analysis of cardiovascular outcomes in the Canadian LGBT+ community. I will give you a warning, you'll see me bounce between different acronyms because a simple high-level look at the literature, you'll see almost every paper might use something slightly different. Just a little spoiler alert, one that I really like to use would be SGM, sexual and gender minorities, which encompasses, three letters that encompass anybody that wouldn't be, or that wouldn't consider themselves a cis heterosexual person. So yes, the first component would be the technical piece looking at cardiovascular outcomes from the Canadian Longitudinal Study on Aging, the CLSA, which I'll talk about now in just a moment. And then the second component would be a scoping review of knowledge and data gaps in the LGBT+ community with respect to the scientific literature. And then the final piece would be that community and expert engagement that we had talked about previously. I just thought this picture was cute. I don't think it's supposed to be me, but looks like she's doing a lot at once. So I wanted to pop that one in there as well. So like I said, the data is going to come from the Canadian Longitudinal Study on Aging. And so what that is a large national long-term study in Canada that follows, at this point, over 50,000 individuals. And they would have been, as per the inclusion criteria, between the ages of 45 and 85 at the time of recruitment, with a follow-up plan for 20 years or until a participant passes away. So the data was collected in different ways. They would be it would be collected in person at data collection sites or through in-home interviews where data, I guess, research staff will go into the person's home once they agreed to it and collect data in there in-house, making it a bit easier for those people that couldn't, say, physically go to a data collection site. And then some people in the tracking cohort would have been data would have been collected primarily through, or sorry, exclusively through telephone interviews, and sometimes there's a mixture of both. So the data collected in the CLSA would include biological, medical, psychological, social, lifestyle, and economic variables, as well as others. With respect to biological, that could be physical measurements by a research team member, like height, weight, waist circumference, those types of things. Not used in this particular project, but also collected would be genetics, genetic-based data. Some imaging data was also collected. But again, those wouldn't be used for this particular project. But I just wanted to give you guys sort of a scope of just how comprehensive, I guess, the CLSA actually is. And so the whole point of the CLSA would be to understand how those variables impact participants as they age in Canada, both individually and together, and also see how these variables contribute to maintaining health as well as the development of disease and disability in Canadians as we age. I just love how I love how the slides move in this. I hope you guys like it too. This might be old school by now. To me, it's pretty new school, but anyway. So like I said, there is the tracking. At this point, it'd be over 21,000 individuals would be exclusively using the telephone computer-assisted telephone interviews. So that would be referred to as CATI. And then the comprehensive crew, which is the bigger cohort, which would be the individuals that actually have the physical assessments done or have in-person visits with the research team. So data collection started after a recruitment period in 2011. The end of the baseline data collection, as well as the start of follow-up 1, would have started in 2015. And then in between here, we would have had the maintaining contact questionnaire in 2013, just basically reaching out to anyone recruited at that time, just to make sure that they're still good, they're still willing to continue in the study. And at the time of my data request, baseline data was available, as well as the follow-up 1 data up to 2015. Follow-up 1 data finished in 2018, and follow-up 2 data, I believe, is now available for any research using the CLSA moving forward. I just missed it by, I think, a couple of months, but baseline and follow-up 1, I think, are going to be what I need. So, as I said, so the technical portion of the thesis would be a regression analysis using SAS. So the data is going to be actually stored in MUN's CAIR. I'm used to it as CHIA, but I think sometime in the last couple of years they switched to CAIR. I'm not sure what that means. I apologize. I remember I did know this morning, and I'm drawing a blank right now. But so I can access that secure environment through VPN, and then the large data set that I have, which would be, it's 2 compressed files, very large. There's about more than 30,000 lines in each one of the files, but that can be safely stored, and the data can be cleaned and analyzed in MUN's virtual network. So very timely for this presentation, because just this morning, my data was MFT'd into the environment. So I'm happy to say that I can soon start to clean the data, check the data. One of the first steps, I guess, would be to see if there's any, oh, I'm just getting a chat notification popping up. I'm going to check there. Catherine, thank you. Center for Analytics, Informatics, and Research, pronounced CAIR, C-A-I-R. Thank you, Catherine. Or was that you, Amy? Whoever it was, thank you very much. So yeah, as I said, one of the first steps now will be to check to see if in all those 30,000 plus lines of data, if there's any repeats or duplicates with the unique identifiers. If there's even one, I've been told it could be a headache. So the data cleaning and the data checking and the merging of the data files into one is going to take, I think, quite a bit of time over the next few months before I get into the analysis. And I'm going to have a little side note here with respect to the community engagement. The group of volunteers for this project, we have actually met once, which I'll go into a little bit more detail in a little bit. And so now that I have the data, the next time that I would actually meet with the volunteers would be once the data analysis is finished. So hopefully around about Christmas time would be lovely. Of course, my original timelines keep getting pushed off because nothing ever happens as quickly as you think or would hope it would with respect to approvals and agreements and data release. So anyways, once the data is cleaned, I can start the analysis, and some of the variables that would be used to determine cardiovascular outcomes in the Canadian LGBT community would be history of cardiovascular disease, history of ischemic stroke, or any other cardiovascular events, lifestyle and physical activity questionnaires. History of smoking is pretty comprehensively captured, which from what I understand is not always the case, as well as the presence of other cardiovascular comorbidities such as diabetes and obesity, and then other standard baseline characteristics such as age, sex, and physiological measurements. Alrighty, there's that pesky home button. I thought I could be slick and press the next button and it would just come back, but I must have missed that one. So yeah, like I said, before I even began, I guess, or before the final protocol was in place, one of my committee members had suggested that I speak with one of their colleagues who works in BC on aging LGBT research. Her name was Dr. Gloria Gutman, so she would have been the first expert that I engaged with. And like I said, I didn't plan on doing that in the beginning, but having that first conversation with her kind of cascaded into me speaking to roundabouts 10 experts in the field, some of them through email, very, very, very quick correspondence, some of them in informal interviews, just via things like this Zoom or Teams. And like I said, once I had started the ball speaking with Dr. Gutman, I ended up speaking with people across the country, spanning from BC, Nova Scotia, Ontario, Newfoundland and Labrador, of course, and even someone from California. I was quite jealous when I was speaking with him. That would be one of Dr. Gutman's close colleagues who's worked with her on other projects. He's from BC originally. I think he's semi-retired in California. So of course, speaking to him last fall when it was starting to get kind of cold and wet out here and seeing the palm trees going in his back behind him in the window, got a little bit jealous, I can't lie. So once I started speaking with these experts, again, it was interviews that were informal and not recorded. Again, this would have been before any approvals were in place. So this was all part of the study design process. I did take detailed notes through each meeting, and that helped greatly in being the backbone, I guess, for my literature review, as well as shaping sort of the direction of where this project was going. And I guess most importantly, I wanted to talk to them about what was done and what was missing in the literature to make sure that what I was planning on doing was a good idea and not already done somewhere else. With respect to the experts and working with the CLSA, some of them hadn't heard of it, and then some others had used the CLSA specifically and extensively for multiple projects. And once I spoke to all of them, I guess the consensus was, first and foremost, that cardiovascular outcomes in sexual minority groups is limited at present. Secondly, the CLSA would be a good database to use, a good data source to use to study cardiovascular outcomes in this community, this very complex community at a national level. And number three, they confirmed that standard healthcare data collection tends to be heterocentric, again, contributing greatly to the data capture gap. So a lot of the times you'll see, gender, M or F. And in other times you might see sex, M or F, or sex at birth, M or F. And then you might get that secondary question of orientation, sexual orientation, or gender. Most often though, you see that M versus F and no other way to identify beyond one or two. I did make a quick note here to say I was very happy to see that in the most recent Canadian census, the 2021 census, for the first time they did drill a little bit deeper. So they asked for sex at birth, M or F, and then they followed up with your gender, how you identify now, and your orientation. So they did collect, they did dive a little bit deeper so that more people could be represented. And again, I was thinking primarily of non-binary comes to mind, transgender, two-spirit, which previously would have been lost if you just asked, are you M or are you F? And then finally, the fourth the fourth point that they all seemed to agree on was that the utilization of a community volunteer group to act as a steering committee for this project was a good idea. No surprise there. That was one of the parts about this project that I was actually most excited for, because I'd never done anything like that before. So again, the experts in the field, a lot of their work is going to be contributing to the literature review section of the thesis. And we can see right here, this is just a quick grab of one of the list of publications I have on aging LGBT members in Canada. And right off the bat, we can see Dr. Gutman and then her colleague, Dr. DeVries. I hope I'm saying that right. Sorry if I'm not. You can see that they're here multiple times already. And another person, Dr. Stinchcombe, was a fantastic resource. He's, I believe, based out of Ottawa, and he has worked with the CLSA extensively, looking at mental health outcomes in LGBT community members, as well as looking at other things like cognition and memory using the CLSA. So he was a great resource when I was trying to think about how will I actually use the data from the CLSA. So I think one of the funnest parts of this, or I guess one of the more surprising parts, was how open these people were to speak with me. So, you know, it's not just names in a citation list, but now I actually know what these people sound like, what they look like, what they do. So as a PhD student, that was a really cool aspect of this process. And additionally, one expert from this group of people he crossed over and became a member of the steering committee as well, one of the volunteers. So I thank him very greatly for that. And he's a fellow Newfoundlander and Labradorian as well. Alrighty, so after I spoke with people who have done research in this field and got a sense of what was missing and got a sense from them what they thought of going ahead with this project, the next step would have been recruiting people from the community to act as a steering committee. So this all happened last fall, so fall of 2021. Very, very quick to make something like this using, there we go. Using Poster My Wall, just a free platform that anybody can use. A free account can get you all kinds of access to all different templates. Of course, the premium ones you'll have to pay for the subscription, but for things like this, it's a great resource to do very nice looking and very easy to make recruitment posters. So this was circulated through different listservs and through a bulletin board at the town hall in my hometown, which I'll get into in just a few moments. But very simple. It just basically asks for volunteers to act as a advisor committee for a PhD project in the ClinEpi program in the Faculty of Medicine. And we would like to have diverse voices and perspectives and representation from all over Newfoundland and Labrador. So again, Dr. Etchegary had mentioned that there was a bit of a time constraint on this particular project. So we did keep it sort of more local for now. I wonder what would have happened if we had more time and if I could have posted it more nationally. But we did end up with a handful, which I'll get to in just a few moments. And at that point, we had let them know that we would be asking for about 3 hours of their time, 3 different meetings up front in the development stage, then again at the end of the data analysis, and then at the dissemination phase once everything was complete before, I guess, the final publication or the final project was done, just to see if they had any last thoughts, what they thought of the project. So that'll be coming up next year. So yes, like I said, this was posted through a couple of listservs. I would like to speak about Quadrangle because I think the work that they do is fantastic, and they very graciously agreed to distribute the poster. I do plan on volunteering with this group in the new year once my schedule is a little bit less hectic. And I just wanted to run by their mandate really quickly, just because I really appreciate what they do. So they're a Newfoundland and Labrador organization that tries to agglomerate and make accessible resources to people of the SGM, still getting used to that one myself, community. And they do this by a 3-pillar mandate. The first one is to address and prevent specific problems facing by the to LGBTQ2IA+ individuals by establishing and operating a community center with structured programs, including social support groups, information programs in sexuality, peer counseling and mentoring, as well as referral services based on their identified needs and goals. Second mandate is to advance education and raise awareness about specific problems faced by the community by providing education seminars for the general public. And third, to address 2QIA+ individuals' unemployment by providing job skills, training, and employment assistance based on their identified needs. So a lot of good work coming at a Quadrangle, and I know that they're looking to expand their research, expand funding and resources. So I just wanted to take a moment to give them a special shout out. And I did want to mention, just to keep things nice and open, nice and transparent. So the recruiting of volunteers for the committee was done before ethics approval, but again, no data was collected prior to full approval from the HREB. So I just got to cover myself there and give that little disclaimer. So we ended up with a grand total of 7 volunteers. And Dr. Etchegary did mention to me that it is hard to recruit volunteers. It's not as easy as one might think. And you know, I totally believed her. I still expected to get maybe 10 plus, but I was very gracious to get 7. And I say 7 minus 1 plus 1 because 7 volunteers did come from the original recruitment plan. We did lose one before Christmas, so just lost a follow-up. They just stopped responding to emails, which again is all part of this this process. And then we had that one, I'll say, expert turned volunteer who came over from the experts cohort. So our final total was 7 members on the steering committee. And for full disclosure, 4 of them came from the poster that was posted at the town hall in my hometown. So 2 of those 4 members are people that I do know personally, and 2 others are people that I know as acquaintances, but 4 of them were very happy to join on once they saw my poster. But again, just to say that, all this to say that at the end, the poster was responsible for recruiting 2 out of the 7 volunteer members, just to have some expectations and realities with respect to recruitment for something like this. And again, I had a short amount of time to do this, and again, kept things quite local. So I'd like to, I often wonder what could have been if we had, say, more time and more, a wider, I guess, scope of the recruitment poster. And important to note that during last fall, we did have another COVID flare. So all interviews were done remotely. And again, due to time constraints, we did do them individually. The hope would be that for the second one and the third one, I really hope for the third one too, at the end, that we can come together as a group, even if it's virtual, since these people are spread out geographically. But I do hope that we can have those as a group. And I don't think there's going to be any issues with that moving forward. So as I said, we did have meeting 1 already, and I did ask I did have a script, I guess, that I followed with these 7 questions, which I've shortened just to fit on the slide here. But just very basically, I asked them to tell me about themselves, why they wanted to volunteer, and anything about their personal self that they would like to share. Next, are you comfortable sharing your opinions and meeting with others in a group setting moving forward? Everyone agreed to do that. The third, I guess, one of the more important questions, I gave them an explanation of the variables that we requested for the regression model and asked them, do you agree with these variables being important for this study question? Why or why not? All members, I'm happy to say, did say that the variables being requested were, I guess, appropriate for this study question. Next, what other factors do you think are important when looking at cardiovascular health in the LGBT plus community? Some members didn't have anything else that they wanted to share. A couple did have a couple of unique ideas. I'll get to those in the next slide. Next, I asked, do you think this type of research is important to the community and why? Next would be, who could benefit the most from this type of research? And then I finished up with just confirming that I would like to speak with them a second and third time, and the next meeting would happen after data analysis. And everyone thankfully agreed to meet with me again. So some key takeaways from the first meeting with the community advisory group. All members of the committee did identify as non-heterosexual and were okay with me sharing that about them. No member voiced opposition to the protocol or the project, and they all did agree that they thought it was a good idea. They thought that the variables were appropriate. as I said, all members voiced that the project seemed valid and important to their community. With respect to the variables that are available through the CLSA, the list that I had gone through with the members, most members voiced smoking, mental health, and physical activity would be high on the list of important cardiovascular disease variables. And then, as I said, a couple of members had a couple of suggestions for something else we might look at. One member voiced steroid use in gay men might be an important thing to look at. I don't think that's going to be captured through the CLSA. There might be a mention in medical history or medication history. I've got to dig a bit deeper into the data to see, but I don't think that's something we can address for this project. And then another member voiced that the use or abuse of drugs and ethanol as being an important thing to think about. And then they went on to say, especially in Newfoundland and Labrador, where rates tend to be higher than the national average. And then at the end, all voiced the importance of this work to the LGBT plus community. And I guess one sentence to just summarize how they all felt was that it was giving a voice to a marginalized community, basically letting them have a say in research about them, which I think is pretty novel to people in the general population. So, as I said, the next step would be dive into the data head first with my scuba gear. Hopefully I won't get lost. So at this point, everything is approved, ethics approvals in place, agreements are in place. And as I said, just this morning, the data was MFT'd into the magical world of care. So I can start to get my teeth into that. And then hopefully by late fall, that would be the next meeting with the volunteers where we get together to discuss the results of the regression modeling. So basically the state of cardiovascular health in LGBT plus community as seen through the lens of the CLSA data. And we're getting close to the end, I promise. Some important things to consider with respect to the volunteers. So yeah, volunteers are hard to come by. I really was in my naivety expecting a handful more, but again, I'm very happy to say that I do have 7 committed members that at this point are committed to staying to the end of the project. And again, just to reiterate that, well, the poster did recruit 3 volunteers originally, but one of them did, like I say, get lost to follow-up. So ultimately, the poster, the recruitment poster was, I guess, directly responsible for recruiting 2 volunteers. And I have to say, volunteers are fantastic. So those that do volunteer their time to become engaged in things like this, in research like this, they're all in. If they agree to do it, they're very engaged, they're very passionate about it, they're very willing to spend time and give their opinion. And it's not just, I didn't get the vibe from any of them that they were just, you know, oh, I guess I'll do it for the sake of it. They all seemed very engaged and very, very interested in the project. One thing to note though, the last point there, volunteer trend. So with respect to the volunteers that I was able to recruit for this project, I think it was important to note that they all had pursued higher education. And so we must consider that generalizability to the general public might not be as easily translatable in this case, where, like I said, all of the volunteers sort of had that background in at least an undergraduate degree, I think. So again, I think it's important to note. And I do believe the smiley face indicates I am right. Okay, that is the end of my speech. And thank you very much for listening, and I'm happy to take any questions.
Too funny. I will just say the recruitment of any volunteers is tough. It's not easy. People are so busy, so, you know, lives are so full, so it's not easy. And there was very limited time here, really. Listen, I just want to start us off with a question. Perhaps I should already know the answer because I'm on Shane's committee, but I don't, so forgive me. So, you know, remember we were talking earlier about, you know, different levels of engagement and being, you know, engaged across all the different parts of a research project when it's possible. Here, I don't believe that was possible just because of the nature of how quick this had to be done. But I was just curious because from my own experience, I have yet to have a patient partner who told me, yes, I want to be involved in your analysis with your stats, with your variables. I've never had anyone tell. I always offer. I always say to them, you're welcome to work with me through this. Not one yet has said yes. It's a big joke amongst me and many of my patient partners. I talk about it in every presentation because it makes me laugh. I'm just curious about your volunteers. So you're going to meet with them again once you've done the data analysis and so on. Was there ever any talk with them about having to having them involved in any other way if they wanted to kind of sit in with you and have a look at any of the data. I don't even know if that came up, or maybe they said, yes, don't contact us again until you've got some results. Just curious.
Well, I'm very happy to say nobody said don't contact me, so that's good. I didn't actually think about asking that, so that's a good point. Nobody did offer that, and when I sort of explained to them when I was speaking with them, I did say, getting your opinions up front for what we plan on doing. Do you think it's good? Do you think this is valid, and why? And then the next time we speak will be after the analysis is done. So I didn't offer that to anybody, but nobody asked to be a part either.
Yeah, said otherwise. That's right. Yeah. I was just curious. Yeah, just curious. Sheer curiosity on my part.
I think that would be, like you said, you do work with patients a lot in your research. I think that would be kind of fun, especially if it's somebody who's got that, I guess, maybe a master's level or even an undergraduate level who wants to
get involved with that. Not everyone would. That's right. Yeah. Just curious. No, just curiosity on my part.
Thank you.
Thanks, Shane. That was a great presentation, and I loved your Prezi work.
Thank you. Thank you.
I haven't seen that before. So we just got a few comments. So that Zara, I think, she had to leave for another meeting, but she said, thanks for sharing your research experience and all points mentioned above, public engagement and partnering with them, which is important for our clinical research. She has some questions, so she's going to reach out to you later.
Yep, absolutely.
Catherine Street wanted to know, what was the age breakdown of the volunteers? Because we often find volunteers are retired, white, well-educated women.
Okay, absolutely. So age range would be from late 20s to early 80s. All but one is a man that identifies as being a gay man. And then we had one female identifying as, I believe, non-binary. So with respect to, I guess, again, sex, we would have had mostly male, mostly identifying as gay men. But again, the age range was quite large. And I guess since in the question it said retired, white, well-educated, I will say well-educated, yes, and all are white as well.
Thanks.
You're welcome.
Any more questions or comments, anyone?
Is there, I think at the chat open, there's another one from Catherine. Sorry, we have two patients working on a patient. Ask me in a few months how that went. Okay.
I just said I cannot wait to hear about that. Can't wait to hear about that. Yeah, gotta say, can't wait to hear about it.
I'm gonna be bad and come off mute. I'll come and tell you, Holly.
I love it. Yeah, I can't wait. Can't wait to hear about it. But Shane, that like Catherine says, that really is a good age range. Good, great. I'm glad about that, as we often do get limits to generalizability there. So that's good. Yes, that's not a bad thing. Excellent.
Thank you.
Right.
Any other questions or comments?
I might be naughty and unmute, Amy, as there's only a few of us here. Shane, we run various other events such as our Science, Health and Research Education Summit, which runs in November. We may call on you next year, depending how your analysis goes, because this is a very different patient-oriented research project to any that we've done within this unit. So I've just got to try and remember that. Holly, remind me next year when we're planning. We won't ask you to do it this year.
Yeah, and it would be interesting actually to see what the results are, quite frankly. It'd be interesting to see some numbers, even descriptive numbers, Shane, no big fancy stats, even descriptive stuff, I think would be cool. So yeah, we'll have to try to remember that for next year.
That's
also our Patient Advisory Council may be interested as well. We do some sort of, I'm going to say teaching sessions. It's not really teaching session, but we have a 45-minute slot for specific topics. So again, Holly, let's have a think about that as well. If you don't mind, Shane, I'm just throwing loads of work at you.
Oh no, I do love stuff like this. I said to Dr. Etchegary in the beginning, I'm a little bit nervous, but I think that's starting to get washed out at my age now. It's starting to become less of a thing. So I really enjoyed this. I was hoping for a bit of a bigger turnout, but that's c'est la vie. But I would love to continue with this stuff. Absolutely.
Yeah, we'll follow up. Don't worry. We know where you are.
Yes. you sure do. Any other questions or comments?
Oh,
is it okay if I just speak versus typing?
Of course.
I'm Charlene Walsh. I'm with the Marine Institute. I'm a PhD student in the School of Maritime Studies, and I'm not doing patient research, but I'm looking at underrepresented populations as seafarers. And so I've been finding these sessions awesome. And this one in particular has been so helpful because some of the kind of engagement that I would like to do is with women and including other underrepresented groups, like members of, and I'm going to use your acronym, Shane, the SGM, because the other letter never fall easily off my tongue. But I have to say I found this session very helpful. And I'm wondering if anybody has any experience in bringing together, say, underrepresented groups like women and the SGM groups into research projects together versus as separate considerations.
Well, I guess I'll just start by saying this was the first time for me to do something like this. So I'm sure I have, if I were to do this again for another project, I'm sure I have lots to learn. And like I said, if I were doing something that had a little bit more time, doing something that maybe resources were a little bit more available, maybe things could have gone a little differently, but I'm not quite sure how I would have done things differently on this end of things.
Yeah, your project seems very much about a specific audience, and that's very, very valuable. I think for my particular situation, there's a lot of underrepresentation of women, but it's not, I don't think that's clearly just the picture. Sorry, Holly, I interrupted you.
No, not at all. I was just going to jump in quickly to say that we're certainly happy to chat with you about that, Charlene, in more detail if you want to. Certainly trying to engage with underserved groups and whatnot. I think that there's no one easy, quick way, by the way, to do any of this. Really, it's not. Some of it's a bit of trial and error. I've often found word of mouth is the most effective way to recruit and find patient partners, to be honest. You talk about it widely, loudly, and wherever you go, and tell everyone you know, which sounds really simple, but in fact works. I have really found that to work. But some of it, I think, is it does require a bit of thought up front. And in Shane's case, we didn't have a lot of time for a variety of reasons. But if you've got a bit of time to think about it, have a discussion with our unit, with me or any of our patient engagement great folks, might be helpful to begin to brainstorm ideas,
Thank you for that. That's great.
Yeah, and that's.
You're on mute, Holly. Holly, we missed all that. You're on mute.
Sorry, I said, and there's lots of resources on our website as well, right? Which is a good place to start as well.
Excellent. Thank you.
Charlene, I wanted to say, you said you're at the Marine Institute. I just wanted to say, I think that's really awesome. My sister-in-law, well, I'm not married, but I guess will be eventually. I guess my sister-in-law, she's a new professor over there, and she absolutely loves it. So I think you work in a very cool spot.
There's a lot of interesting things going on up here these days. So yeah, very much so.
Okay. I don't know if there's any more comments or questions. Anyone?
I don't see anything in the chat.
No. Okay. Before we go, I'm just going to share my screen for a sec, just to share some of our.
Oh, I just took mine off, so you can go
sorry.
ahead.
So most of you probably already know. Can you see the upcoming sessions?
Yep.
Okay, so we have a research design series, which you just participated in. Right now, we don't have any speakers in October, but we're hoping to have some in October, maybe December, just because there's a lot going on in November. To register for these events, you can go to nlsport.eventbrite.ca. And like we talked about at the beginning of the presentation, you can check out past events and recordings on our website. So like I said, it's a free training program. If you complete 6 sessions, you'll receive a letter of completion. We used to have one in person, but since COVID hit, they've all been online. So you can sign up at nlsport.mon.ca, and registration for each event is required. So like I said, you can go to our Eventbrite page, and if you have any questions at all, or want to be able to reach out to any of the presenters, you can reach out to me at amy.han@med.mon.ca. So that's all I want to share.
Thanks, Amy.
That's
Always appreciate your moderation.
Oh, thank you. Thank you for presenting today.
Perfect. Thanks, everyone.
Thanks, everyone. Thanks, Shane.
That was good. Thank you.
Thank you so much.
Thank you, everyone.
Thanks, Shane. We'll chat soon.
Absolutely. I'll send you an email right away.